All right, February 11th. Let's get started for our Q&A weekly session.
All right, so got 6 questions. So let's start. First one. So, what cases do you recommend for primary canine extractions? So, traditionally, primary canines are extracted when there's anterior crowding and there's not enough room for the lateral incisors to erupt cleanly. So the concept behind this process of removing primary canine teeth, usually in the lower arch, is to start the process of serial extractions. Serial extractions are done under the premise that the mandibular arch width is predetermined and that there's either room for the teeth or there's no room for the teeth. And it's a genetic expression of the maximum potential for that child. As such, a game of musical chairs or favoritism is played. Obviously, anterior teeth have priority, and permanent anterior teeth have priority. So when there's crowding in the lower arch, it's expressed as the laterals not fitting properly. So canines are removed, primary canines are removed to allow the laterals to settle into place. That, of course, does resolve the crowding issue for the incisors, but does nothing to improve the arch form for the remaining yet to erupt permanent teeth. Obviously, when the laterals move into the place where the primary canines used to be, the incisors align and the improvement of the presentation becomes obvious. However, when that situation arises, the permanent canines are blocked out. When the permanent canines start to erupt around 10 years of age, they cannot do so because of the crowding transference from the front towards the middle. So the next extractions in the series arises, and that is to remove the primary first molars or the Ds. As the two arches need to be coordinated, very often a decision is made to also do the same at that timeline for the upper Ds as well. When they have been removed, space will be created for the lower canines, the permanent canines, to erupt. And space will be created for the permanent upper premolars, the first premolars to erupt. When the canines have erupted, the upper first premolars will begin to come down a little bit earlier than normal because of the pathway opened up by the extracted upper Ds. When those first permanent premolars erupt into place, a decision will be then made to extract the lower E's to allow the first lower permanent premolars to erupt. When all four permanent premolars have erupted, the premolars are then extracted, and now we have room for incisors, canines, and the second permanent premolars. And in that way, the crowding is resolved for the remaining teeth, which are the centrals, the laterals, the permanent canines, the second permanent premolars, thereby resolving the crowding issue by removing four bicuspids and hopefully reducing the need for fixed braces at a later point in time. So that's the concept behind canine extractions in the primary dentition. From the perspective of what we do in postural orthodontics, assuming that we have a younger child to deal with, that crowding of the incisors, which materializes at around 7 years of age, 8 years of age, we resolve by arch expansion in the lower dentition. If we have that opportunity, then we create room for the permanent canines and the permanent premolars and avoid the need for primary extractions of primary canine extractions in the lower arch. The upper arch, primary canines are extracted traditionally to help resolve ectopically erupting permanent canines. Primary canines are theoretically lined directly above permanent canines, so that when the permanent canines erupt, they dissolve the roots of the primary canines and then move into the space that the primary canines used to occupy. In crowding cases, in growth that is down and back instead of up and forwards, the maxilla in particular, forward growth is compromised, and the permanent canines, which are the last teeth in the series to come through at 13, end up in an old pathway designed to anticipate forward growth, but because there's no forward growth due to poor posture, those canines end up very high in the buccal sulcus, or they can end up impacted in the palate. In those circumstances, when this is evaluated radiographically and predetermined that there are going to be issues with this, then primary canines are extracted to create an open channel and hopefully direct the permanent canines into place. In postural orthodontics, we also do the same. We develop the arch form in the lower, we develop arch form and suturally in the maxilla. If after we've created the space that we need, yet we're still dealing with ectopic canines, then once the first premolars have erupted into place, but prior to when the permanent canines are due, we will hold the permanent first premolars from drifting forward and extract the upper C's or primary canines to allow the permanent canines to change course and hopefully drift back into place. All right, so that's primary canine extractions. Next question is, when do you recommend Froggy Mouth? So Froggy Mouth is an appliance designed by a French orthodontist that retracts the lips, and when worn with the head level or perpendicular to the ground, in order for a child to control their saliva flow from running out of their mouth. It forces the child to develop a correct adult physiologic swallow. So the rationale behind this appliance is the lips are retracted so that there is no lip seal, and saliva theoretically will flow out the sides of the mouth. Our natural instinct is to not allow that to happen, so we swallow saliva. But because the lips are retracted, the only way that we can comfortably swallow our saliva without the appliance being displaced is with the teeth in contact and an adult wave swallow with the tongue squeezing up to the premaxillar and then the hard palate and then finally onto the soft palate. And so we drive a switch from a, a hyperactive facial swallow pattern that is a suck swallow action to an adult physiologic swallow, which is teeth in contact and tongue squeezing in a wave motion from the anterior to the posterior palate. The appliance, because it also retracts the lips, quietens down the facial muscles and quietens down the mentalis. So in total, it's an appliance designed to switch from a hybrid incorrect suck swallow to a correct adult physiologic swallow. We use the Froggy Mouth in my practice. It is a new appliance for me that I've only just started to implement, and so I haven't fully developed my protocols, but physiologic swallows are structurally only possible when we have nice occlusion and reasonable balance in the bite relationship and adequate space for teeth and the tongue. So Froggy Mouth is a finishing program for us. After we've completed our structural changes with the stage one appliances, aligned the existing erupted permanent dentition into a nice balanced relationship. When we can have a reasonable bite relationship in AP, when we have adequate space for teeth and the tongue, and we are effectively finished with our structural changes with our appliances, then we use Froggy Mouth to kickstart the GoFX, or the Good Oral Finishing Exercise Program. Children who have minimum malocclusion, who are not in need of a lot of structural changes, they can use the Froggy Mouth as a standalone treatment as well. Theoretically, it can be used at the end of any treatment. Fixed braces, aligners, whatever. It's a finishing therapy. Designed to change the swallow pattern and to develop much stronger optimum resting posture. Next question is, can patients begin GoPex even prior to their treatment start? Or must they wait for it during treatment time. So GoPex works on improving a child's resting posture by focusing on refining their function in meals and in regular conversation speech. So effectively, it is table manners, dining table manners, and speaking manners. So those activities, learning to eat like a grown-up, learning to speak like a grown-up, can be used for every child on the face of the planet who can eat and who can talk. So as GoPex is effectively just table manners and speaking manners, you can be a standalone recommendation. It can be a pre-treatment recommendation. It can be a simultaneous to treatment recommendation. It can be ongoing recommendation for as long as it takes a child to learn speaking manners and table manners. During track 2, I mentioned several times to different participants with patients was ready for select GoPex exercises. I had expected that all GoPex exercises would have been beneficial at the start points and not previously realized they had specific start points. So there are circumstances where it's not appropriate to do the chewing at the dinner table exercise. And that circumstance specifically is for cross bites. When a child has a cross bite, they have a scenario where they may have a functional shift in the condyles. They may have um, an action that locks them into a specific malocclusion. In those circumstances, we don't recommend any form of the chewing at the dinner table exercises until that crossbite has been rectified by changing the structure with our appliances. In those circumstances, the GoPex training is held off until the crossbite is resolved. And that crossbite can be class 3 anterior only. It can be class 1 with a transverse crossbite. But we don't implement the exercises until the crossbite has been resolved. That's the primary situation where we don't begin with the exercises. Is this a common issue? A lot of kids have a crossbite. It's a very common imbalance, and that's why it is not uncommon to see a staggered approach in the treatment. Some children, if we are uncertain whether either they or the parents have the maturity to handle the treatment, we ask the parents to begin with the exercises and we get a sense or a gauge of how much discipline there is in the household. So the flip side of the coin is you can, some circumstances, utilize the exercises as a means of screening out inappropriate families who will not have the discipline to carry out the postural changes and therefore are not really good candidates for postural orthodontics. All right, so thank you for Carlotta. Next, next question is how long is the retention phase after active expansion? So retention is a concept that uh, is there for us to stabilize the changes that we have made artificially. You know? So if you were to treat an older child, like a teenager or an adult, and they had teeth that were in malocclusion, we know the most stable bite relationship is the presenting bite relationship. So we know that if we alter that relationship, then we're fighting the neutral zone and the biological drive through postural habits that that patient has to maintain that relationship for the best possible compromise between what's correct and what isn't correct and what's survival related. So we know that at the end of our orthodontic therapy, in order to maintain the changes, the favorable changes, we would then move into a retention phase. And that retention phase is theoretically indefinite. From postural orthodontics, as an interceptive or early intervention therapy, we want to make change and we want to hold that change until the child learns to control the space wisely themselves, or until it is time for that environment to change due to the next phase of growth and transition from primary to mixed or mixed to full permanent dentition. So the retention phase in postural orthodontics is dependent on how quickly the child develops change to their posture from poor to optimal, and also the biological age that we finish the therapy and at what point do the teeth start to change over. The critical juncture for changeover is in the preteen years where the second primary molars change over, the 13-year-old primary canines are lost for the 13-year-old permanent canines. And it is normal at that point for leeway space to close. When that point arises, where the last of the primary teeth are lost and leeway space is closed to allow the 12-year-old molars to erupt into position, that period is when artificial structural retention is dispensed with, and the focus becomes retention through management of posture, just through the exercise programs of table manners, speaking manners, and the swallow pattern with the water GoFX exercises and or the Froggy Mouth. So retention continues until the final transition out of mixed dentition into permanent dentition. Okay, next question is two questions about early interceptive postural orthodontics. First question is, will it be extended to newborns to correct pathological tongue posture if present as soon as possible? So postural orthodontics is correcting, by definition, is correcting oral posture during orthodontic treatment. So orthodontic treatment does require teeth because that's the correction process. So my target audience is in early interceptive postural orthodontics are biologically aged between 4 and 10 years of age. So I don't actually have any involvement in treating pre 4 years of age. Um, yeah, so I don't have any real knowledge base, any real experience, and any treatment protocols for children under the age of 4. Now, can one apply the concepts of correct posture, correcting posture for children younger than 4 years of age and inclusive of infants? And the answer is yes, of course. What are some of the things that I suggest to ensure that posture and function is not compromised in those early years? And my primary and only real recommendation for pre 4-year-old children is to avoid parental spoon feeding of their infants. Feeding off a spoon is normal part of life, but should begin under a child's own use of a spoon, right, with their own hands. I discourage parents from using spoons with them holding the spoon and feeding their infant. The common start time for the use of spoons is around 6 months of age, where parents are encouraged to feed their babies pureed foods off a spoon. Generally, until a child has their primary molars in contact, roughly corresponding to the time they learn how to speak, they are not ready to feed off a spoon. Their swallow is still primarily focused on the breast feeding action or suckling. And suckling has a very different action compared to swallowing. Suckling and spoons are not compatible. Swallowing after feeding using a spoon is compatible, of course, but suckling, if we force an infant to feed off the spoon while they're still suckling, you end up with the tongue thrusting the contents of the spoon out of the mouth. And so the concept and invention of the bib came about. While we still need a bib because we are pushing with our tongue forward in a suckling action and not having the capacity to feed off that spoon, we recommend avoiding the spoon. By all means, hand the child a spoon, and if they figure out how to use it, they're ready, but don't spoon feed your infant. So that's the only recommendation that I have. Why is that important? There's a natural transition between suckling to swallowing. That transition, I suspect, is disrupted by too early feeding off a spoon, and the implementation of that becomes a forced action. The parents literally force the infant to feed off the spoon, despite the fact that all the food ends up on the face and on the shirt. So the infant learns to suck swallow or a hybrid suckle in order to get through that forced feeding. When that happens, the swallow pattern is irreparably damaged, in my opinion. And it's that single turning point action that is the start of the majority of malocclusions because it alters the swallow pattern and thereby alters the resting posture. Next question. How about building on the work of Kevin Boyd, Weston Price, and myself about improving the health, especially the nutrition, both parents before conception to improve sperm quality and increase the likelihood of baby being anatomically normal at birth, including normal tongue posture, swallowing, and growth in the womb? By all means, if nutritional and general health is of interest to you, then push as hard as you want on that. In Australia, the regulations are very strict. The only people who can give nutritional advice are dietitians. Dentists, doctors, any of the medical professions aside from dietitians have actually no chartered rights to provide nutritional advice. In case you are unaware, we had a orthopedic surgeon struck off his license in Tasmania because he gave nutritional advice to his patients. And the Dietitians Association were able to successfully lobby to have the board stop him from giving nutritional advice because he was not licensed, despite being a medical doctor and a surgeon. In recent years, that was overturned through extensive legal battles, but that doesn't mean, of course, there's been any changes to our licensure in Australia. Still, the only people who are allowed to give nutritional advice are dietitians. Flip side of the coin, lots of infants who have normal growth and development, if they're spoon-fed, or develop allergies later on in life, develop poor posture, and still get occlusion. Okay, next question. In the photography setup in the phase 1 notes, when there is a ratio of 1 to 1 1/4 or 1 to 1.5, do we set up that in the camera, or is it when we develop the image? I don't understand. Thank you. So there are specific standardized dimensions that are used in dental photography. Right? Dental photography was designed initially in film camera days when we used slide film. So I learned my dental photography when we were still using ectochrome, right? Slide film. And in slide film photography, there's no adjustment possible to the image in ratios, proportions. So what you take is what you see. And in order to standardize the photography so that every image was taken at the same distance and the same ratio so that you could accurately compare before, during, after changes to the facial form. The macro lenses were designed specifically with guides in the distance of the focus rings to determine the ratio, whether it's 1 to 1, whether it's 1 to 1 1/4, 1 to 1.5, and so on and so forth. this these settings were preset in your camera so that you had the right ratio of distance between you and the patient every single time. So you would preset the lens to focus at that ratio, whether it's 1 and 2.5 or 1 and 1.5. And then you would physically move yourself with the patient being static until they were in focus. And then you would be absolutely guaranteed that the distance between you and the patient was always the same for every patient and for each of the series that you take with the patients. That was standard protocol in the film days and in manual focus cameras. Now, with the advent of autofocus cameras and digital imagery, those rules have become very lax. And the advent of digital photography, the aspect ratio of the sensor compared to the film days has also changed and has become so variable that the profession stopped using that ratio mechanism to preset the distances because it was no longer applicable because of autofocus and no longer applicable because of the sensor sizes. There's a concept called crop sensors and full frame sensors. Because the crop sensors came into play initially in the digital shift, those ratios no longer held true, and you had too many variables. With the advent of autofocus as well, it became easier just to fill the image in the frame and accept whatever image came through. And often use of a scale, like on a chart on the wall, was then used to substitute for a scale instead of on the lens, became on the wall. It became, unfortunately, so confusing for the profession that that aspect stopped being utilized on a regular basis. And so there has been a drop in the standard protocols, I believe, and it's much more difficult to do accurate before and after comparatives. How we overcome this is we accept that we ignore the intraoral ratios and we just fill the frame and use autofocus. And in the extraoral, you can either use a scale on the chart on the wall behind the patient, or you can have a set position that you have the patient stand on and a set position that you have the clinician stand on. And you, so long as you maintain that set position, then your distances and ratios are approximately correct. So it's not as accurate, but that's just how it is. So the next question is the same. In order to fill the frame at the right ratio, if you're using a film camera, you would preset the lens barrel to those ratios of 1 to 2, 1 to 1.25, 1 to 1.5. And then you would move yourself back and forth until the image was in focus. Those ratios no longer apply unless you're using a full frame digital camera, and almost no one uses that in the dental industry because of the size and bulk of the camera and the cost of the camera. So those ratios no longer apply to crop sensor cameras. What we just do now is fill the frame with no superfluous and extra information. So It's a judgment call now instead of a preset ratio. And my only recommendation is just through my own experience of what looks correct, based on what I was taught and learnt during my film days. So I've given you templates to how things should look, and so long as you can reproduce an image directly off the camera to that view, then that's more than acceptable. All right, I think that's a really nice point to finish on, and thank you so much for your participation.
Oh, let me just see. Yep, I think that's it. Thank you, Simon.
Yep.
Just so everyone knows,
Um,
next week we will not be on. It's Chinese New Year. Take a little break. We'll be back in 2 weeks for our weekly Q&A. All right.
Fantastic. Thanks,
Happy
guys.
Lunar New Year. Thanks, Simon. Thanks, everyone. We will upload the recordings tomorrow. Thanks, everyone. Oh, does anyone have any quick questions? We've got some guests online. Do you have any questions about? We do have a 2-day intro program that might be of interest. I'll just send the details in the chat just quickly. Got a Valentine's special that ends this week. In case you're interested, here's the details. There you go. Yeah, so for those of you who are new to posture orthodontics, if you'd like to join our formal program, it starts with our 2-day program. We had one recently, it was recorded at the Hilton. 2-day introduction to early interceptive postural orthodontics. There's a special on right now. There's a link here, straightteethnaturally.com/special. It's roughly 50% off. Sorry, 30% off. Check it out. All right. Thanks, everyone. Have a good day. Bye.